Dr. Hirsch and Dr. Flores wonderfully discussed the advances that have been made in the past several decades in terms of understanding the biology and then advancing the therapeutic landscape of lung cancer. It is also becoming very important to understand and recognize some of the side effects associated with the targeted therapies for lung cancer for safe and effective therapy. Next slide, please. Next slide, please. So there are about 21 unique agents that are approved by the FDA for treatment of non-small cell lung cancer. And here in my talk, I'm going to focus on EGFR, ALK, and ROS1 genomic alterations given the time. But some of the principles and suggestions can be applied to the side effects that arise in the setting of other targeted therapy drugs. Next slide, please. So EGFR is a molecule that is widely expressed throughout our body, and so it is not surprising to see that various organ systems are affected by EGFR inhibitors. So here I'm going to focus on skin, GI side effects, and some of the rare side effects, but important to recognize the pulmonary and heart side effects. Next slide, please. So when EGFR is inhibited in the skin, there are several changes that happen. First of all, there's an alteration in the chemokine expression in the skin, leading to recruitment of some of the innate and adaptive immune cells, such as macrophages, dendritic cells, and T cells. And this is followed by alteration in the differentiation of the epidermis, which is the upper part of the skin, and also change in the expression of antimicrobial defense genes in the keratinocytes. And combination of these factors lead to the development of skin toxicity in the setting of EGFR inhibitors. Next slide, please. So this is a general timeline of skin side effects that develop with the EGFR tyrosine kinase inhibitor therapy. First, we see rash and itching develops, followed by dry skin, skin fissures, stomatitis. Stomatitis means oral cavity inflammation, and then sores, followed by nail changes thereafter. Next slide, please. As Dr. Hirsch mentioned, there are 3 generations of EGFR tyrosine kinase inhibitors, first, second, and third generation. And based on the FLORA trial and others, we utilize third generation treatment more often than the earlier generation inhibitors. So with third generation EGFR inhibitor, such as osimertinib, the instance of rash is less compared with first and second generation drugs, and it ranges from 40 to 50%, and it is rare to see a high grade 3 or higher rash with the third generation EGFR inhibitor therapy. The itching and the dry skin are seen across all the EGFR tyrosine kinase inhibitors. In terms of paronychia, so paronychia is a term to describe inflammation or infection around the finger or toenail, happens across the generations of drugs. However, perhaps more commonly with second generation. In terms of third generation inhibitor therapy, the range of paronychia instance is from 20 to 30%, but again, it is rare to see high grade paronychia with the use of third generation inhibitors. Next slide, please. So I'm showing you some of the pictures that really exemplify the acneiform rash, the acne-like rash that happens with EGFR inhibitor therapy. The picture on the left is a patient who is taking first generation EGFR TKI therapy, and you see that there's sort of pimples on the face and then pus-filling lesions as well that are tiny. And on the right is a patient who is taking osimertinib, which is a third generation EGFR tyrosine kinase inhibitor, showing a little less degree of rash, as you can see. Next slide, please. And how do you manage acneiform rash? And this rash can have several impacts because of the appearance and then the itching associated with sometimes pain. And when the rash is mild or grade 1, defined by less than 10% body surface area involved, we think about using topical corticosteroids. And for the face and neck, we think about using low potency steroids such as hydrocortisone or moderate potency steroids such as triamcinolone. And for the body, for the trunk, we can go up a little higher on the potency of steroids such as clobetasol cream, which is considered a high potency steroid cream. And this can be supplemented by topical antibiotics such as clindamycin 1% gel. And when the rash is mild and grade 1, we usually continue the therapy. Next slide, please. When the rash becomes moderate or grade 2, defined by 10 to 30% body surface area involved, we still use topical corticosteroids. Then we think about using oral tetracycline antibiotics such as doxycycline and minocycline. And the way I use in my clinic is that I assess patients frequently every 2 weeks or so to determine how long the patient may need to stay on the oral antibiotics. And unless the rash is intolerable, there is no need to interrupt the therapy. Next slide, please. When the rash is severe or grade 3, defined by more than 30% body surface area involved, we use topical steroids, oral antibiotics, but then consideration can also be given to a short course oral corticosteroid so that the steroids can go everywhere. And we can, for example, prednisone 0.5 to 1 milligram per kg for a few days. And then in the setting, we think about holding the therapy. And if there's lesions that have pus or other discharge, cultures can be sent for further workup. Next slide, please. As I mentioned, the EGFR tyrosine kinase inhibitor therapy can cause xerosis, which is a dry skin and sometimes scaly, as you can see in the picture. And this can be accompanied by itching. Next slide, please. When the itching is localized, you can utilize topical steroids. But if the itching is more generalized, we can think about using oral antihistamines such as hydroxyzine or gabapentin or pregabalin. These are GABA agonists. For the prevention and treatment of dry skin, we recommend using moisturizing creams regularly or lotions without any irritants such as fragrances or alcohol. For the scaly dry skin, as seen in the prior picture, exfoliants such as ammonium lactate urea can be utilized. Next slide, please. So paronychia can be a very challenging side effect of EGFR tyrosine kinase inhibitor therapy. And the pictures at the top really showing really bad cases of paronychia. You see a red and angry looking paronychia around the toe and fingernails. At the bottom, you see mild cases of paronychia, and nail changes can happen, as I mentioned, and these include nail discoloration and then a brittle nail. Next slide, please. So it is important to minimize the trauma around the finger or toenail, so we recommend wearing comfortable shoes and wearing gloves when doing house chores or doing the dishes, things using hands essentially, and avoid biting nails and cutting nails too short. And when there is a concern about ingrown toenail that may cause trouble down the road, getting preventive correction procedure may be reasonable. And also it's important to apply emollients such as moisturizing creams around the nails so that the area is continuously moisturized to prevent the development of paronychia. Next slide, please. The management of paronychia is quite similar to the rash that I discussed already. When it's mild, defined by no pain, no discharge, no nail plate separation, we can use topical steroids or antibiotics or antiseptics. If it's associated with the pain or discharge, then we use these topical creams, products, but also oral antibiotics such as the tetracycline antibiotics can be considered. If it's a severe, causing severe pain and discharge and infection, we need to think about interrupting the EGFR TKI therapy and utilizing the topical products and oral antibiotics. And at this point, I consider refer patients to a specialist for further evaluation.